Welcome to Inside 340B Report, an insightful conversation between 340B Report's editorial team on the key issues affecting the 340B drug discount program, the nation's second largest government drug program. Hello, and welcome to the latest episode of Inside 340B Report. I'm Ted Slafsky, publisher and CEO of 340B Report. Today, I'm joined by Will Newton and Shannon Young, who are both 340B Report associate editors and senior writers. Before we start, first I want to let our listeners know that we're pleased to offer a special 25% discount to 340B Report first-time subscribers. You can go to the subscribe tab at 340breport.com and use the coupon code podcast25 to take advantage of the discount. I know you will find our news service to be a valuable investment. Also, I want to encourage you to check out 340B Report's new business area podcast, hosted by a longtime colleague of mine, Anna Mangum. 340B Report's 340B 360 podcast showcase leaders from our valued sponsor companies and the crucial role they play in the 340B ecosystem. Those podcasts come out once a month. It's been a busy few weeks since our last episode, so let's dive right in. Today, we're going to discuss the latest 340B related news coming out of Washington, D.C., including the implications of the recently enacted budget reconciliation bill that was signed into law, changes on a key congressional subcommittee that oversees the 340B program, and what is new in a variety of CMS proposed regulations. We'll also give an update on the latest in the 340B rebate saga as stakeholders furiously continue to meet with the Trump administration on both sides of the 340B battle to discuss the draft guidance that the administration apparently is working on. And finally, I'm going to offer a few words of a tribute to my friend and mentor, David Gergen, who recently passed away. Shannon, can you give us an update on what's been happening at the federal level?
Yeah, definitely. So as Ted said, it has been a busy time in Washington, D.C. After several months of work, Congress wrapped up its work on the so-called Big Beautiful Bill, the reconciliation budget. They passed it on razor-thin margins in both chambers, and President Donald Trump signed it into law. As a note, Democrats did not support the bill. A lot of that pushback came over its included cuts for healthcare spending. It included about $1.1 trillion over the next 10 years. The bulk of that, about $1 trillion, is going to target Medicaid. And that's according to the Congressional Budget Office estimates. Those cuts are likely to result in nearly 12 million people losing health insurance by 2034, again, from the CBO. And hospital and health provider advocates have argued that it could lead to several hospital closures and hinder patient access to care. For 340B purposes, an earlier version of that bill included a pharmacy benefit manager accountability and spread pricing proposals that would affect 340B. They're similar to language that was included in year-end spending bills at the end of 2024 that were stripped from those proposals. And like then, that language also came out of the reconciliation bill, but it hasn't completely disappeared on Capitol Hill. Congressman Buddy Carter of Georgia recently introduced a standalone bill with similar provisions, which has drawn support from Republicans and Democrats alike. And we'll talk about that a little bit more in a bit. But first, Will, can you walk us through some of the 340B implications of the Big Beautiful Bill?
Yeah, so as you mentioned, this roughly 900-page reconciliation bill does not mention the 340B program a single time in the final product, but it still has pretty significant 340B implications. First of all, as we know, a lot of 340B providers serve a large number of Medicaid patients. So anytime Medicaid patients lose coverage, that would put safety net providers on the hook for providing more uncompensated care, which is just another financial burden and pressure on them. But the most direct 340B implication pertains to hospital eligibility. So there are several hospital covered entities that rely in part to get their 340B eligibility by meeting a certain Medicare disproportionate share hospital adjustment percentage or DISH percentage. So the actual threshold depends on the specific covered entity type. And the DISH adjustment percentage is this pretty complicated formula, but the main point here is that the number of Medicaid patients that a hospital serves affects its DISH percentage, but the number of uninsured patients that a hospital serves does not affect the percentage. So, what that essentially means is that if a hospital is treating a patient on Medicaid and that patient loses their Medicaid coverage as a result of this bill, even if the hospital is treating that exact same patient without insurance, their DISH percentage would go down. So, this is particularly important down the line for hospital covered entities that are sort of right on the threshold of 340B eligibility, because any cuts to their Medicaid patient population resulting from this bill could potentially threaten their 340B eligibility. Adding sort of another wrinkle to this whole situation that I've gathered from sort of speaking to some attorneys that specialize in this is that even though this is a national federal bill, the impacts of it could be felt pretty differently in different states. And a big reason for that is that roughly half of the $1 trillion in estimated Medicaid cuts over the next decade applies specifically to states that underwent Medicaid expansion. So going back to the Affordable Care Act, right, there was provision that basically incentivized states to expand their Medicaid programs. Most states have now done so, but there are a number of states that haven't, mainly red states for political reasons. And so, in sort of a weird way, states that actually have weaker Medicaid programs that aren't Medicaid expansion states, like Florida and Texas, for example, won't really feel these Medicaid cuts quite as acutely as some other states with more robust Medicaid programs that have fully expanded Medicaid, like California. That said, though, all states are going to feel the effects of these Medicaid cuts in some ways, but it's really going to vary a lot depending on the specific state policy and also sort of how states respond. Some states have trigger laws in place where, a new policy will take effect if they lose a certain amount of federal funding. More states might introduce new legislation to try and mitigate some of these effects. So really important to look at this on a state by state level and prepare ahead for potential eligibility changes that could be coming the next few years. And then sort of completely separate from this, another big implication is now that this huge protracted, legislative battle over the reconciliation bill is over with, Congress can now turn its attention to some of its other healthcare priorities, including some 340B provisions. So, Shannon, I know you've been covering another big bill that you've alluded to earlier. Can you talk a little bit more about that?
Yeah, sure thing. So, as I mentioned earlier, Buddy Carter, who is a Georgia Republican, joined about almost a dozen bipartisan colleagues recently in introducing legislation that targets pharmacy benefit managers, also known as PBMs, they're pharmacy middlemen, and it includes 340B related provisions. So, specifically, the bill would ban spread pricing in Medicaid. And that's a practice which occurs when PBMs retain a portion of the amount paid to them for prescription drugs. It would also set new requirements for PBMs under Medicare Part D, including unlinking PBM compensation from the cost of drugs. It would require semi-annual reporting on drug spending, rebates, and formulary determinations. And it would direct the Centers for Medicare and Medicaid Services to define and enforce, quote, reasonable and relevant, quote, contract terms in Medicare Part D pharmacy contracts and enforce oversight on reported violations. The bill's PBM accountability language requires PBMs that have retail, mail order, or specialty pharmacy affiliates to report a list of covered Medicare Part D drugs subject to 340B agreements. And its spread pricing language notes that the policy applies to drugs subject to agreement under 340B. And so the measure would apply to about more than a dozen states that allow providers to bill 340B drugs to Medicaid managed care organizations and receive reimbursement above acquisition costs. Under fee-for-service Medicaid, 340B providers bill Medicaid at acquisition cost plus a dispensing fee. So 340B provider advocates have hoped to not have to report on their Medicaid managed care savings, but the draft language appears to allow covered entities to bill health plans above acquisition costs, a perceived win for many advocates since it's still an important revenue source in some states. Interestingly, one of the co-sponsors in this bill is Diana Hirschberger, a Tennessee Republican who, like Carter, is a pharmacist. Both of them have been critical on 340B, and both were involved in some recent shakeups on the House Energy and Commerce Committee. Ted, what can you tell us about that?
Yeah, that's right, Shannon. So in early July, Buddy Carter, who's been a longtime House member from Georgia, announced that he's running for U.S. Senate, taking on Democrat John Ossoff. He's asked to go through a primary first, Republican primary. Announced he was going to step down as chair of the E&C Committee's Health Subcommittee. This was welcome news for the 340B provider community, as Representative Carter has been a longtime critic of the 340B program, has really been sort of a leading advocate for significant changes to the 340B program, many of which are backed by the pharmaceutical industry. With his, he's not leaving the House. He's not leaving the House Subcommittee, but he's going to be less involved. The gavel is then turned to Morgan Griffith. Brett Guthrie, who's the chair of the Energy and Commerce Committee, recently selected Representative Griffith, who is a Virginia lawmaker, represents a fairly rural part of Virginia, but includes my daughter's college, Virginia Tech. Take the gavel from Carter. He also named Griffith and Guthrie also named Diana Hirschberger, who you mentioned before, a Tennessee Republican, as the subcommittee's new vice chair. Griffith, whose district includes the Carilion Clinic, which is a large health system based in Roanoke, is generally seen as a friendlier face to 340B advocates than Carter. That's despite raising concerns about the program, as he did when he was chair of the E&C Oversight and Investigation Subcommittee last year, when they held a hearing which looked at the 340B program's growth and what critics say is a lack of 340B provider transparency. Hirschberger has been, is, as you mentioned before, is a pharmacist. She is not a big fan of the 340B program. She was a co-sponsor of a bill called the 340B Access Act that was endorsed by PhRMA and the National Association of Community Health Centers a few years back, that would really dramatically change the 340B program. And some hospitals argue would force 75% of hospitals out of the 340B program. It's unclear whether NACT still supports that type of legislation. They seem to be backing off of that alliance with the drug industry. So we're waiting to see if that bill will be reintroduced in the coming days or months. So there's a lot going on in that 340B space. The Senate Health Committee Chairman Bill Cassidy is also a longtime critic of the 340B program, and that's the Committee of Jurisdiction in the Senate. So, the challenges will continue for the provider community, but perhaps they get a little bit of a break with the elevation of Morgan Griffith.
Yeah, that'll definitely be super interesting to follow everything happening in Congress. And before we continue with our show, we're going to take a quick moment to hear from one of our great sponsors.
Verity Solutions is a proud sponsor of 340B Report. In today's dynamic landscape, having the right solutions and a dependable partner is more vital than ever. Verity's innovative, award-winning 340B program management solutions are designed to optimize your 340B pharmacy spend and maximize your pharmacy supply chain savings. Verity is dedicated to helping you find new program opportunities and streamline workflows, resulting in more resources to enhance patient care. Visit Verity340B.com to start your journey today.
So aside from everything happening on Capitol Hill, CMS has also been very busy recently. The agency has released 2 proposed rules over the past week that have pretty significant implications for the 340B program. Shannon, I know you've been writing about one of those rules. Can you tell us a little bit more about that?
Yeah, so on July 15th, CMS released its 2026 Hospital Outpatient Prospective Payment System, also known as OPPS, proposed rule. And it calls for accelerating hospital outpatient payment cuts to offset previous 340B hospital lump sum payment repayments. It also included plans to survey hospital acquisition costs for certain outpatient medications, something which 340B advocates caution could lead to significant cuts in 340B drug payments. So these provisions stem primarily from a Supreme Court ruling, but specifically they would increase the reduction in OPPS payments to all hospitals that receive outpatient prospective payments. It would also use the lower reimbursement to offset prior 340B lump sum remedies that the agency was required to provide to 340B disproportionate share hospitals after the Supreme Court unanimously overturned a policy in the first Trump administration that reduced Medicare Part B payments by close to 30%. And the hospital groups have been pretty vocally opposed to this proposal. The American Hospital Association, which was among those to successfully sue over the previous OPPS policy changes, called it, quote, inadequate, cautioned that its plan to, quote, claw back billions from 340B hospitals is, quote, illegal and unwise, and raised concerns about the agency's plans to, quote, pursue a burdensome acquisition cost survey. So this has been an issue that's been pretty controversial for a while and has a lot of history. So Ted, can you tell us a little bit more about the background here?
Sure, it seems like deja vu all over again. In the first Trump administration, there was a proposal that the administration under CMS proposed to drastically cut back reimbursement to 340B hospitals in the Medicare Part B, as in boy, Part B space, actually about a 28% reduction in reimbursement. And the hospital group sued CMS and said that they didn't have the authority to make such a dramatic change without doing the proper mechanisms, et cetera, in order to determine whether this is kosher. Ultimately, the U.S. Supreme Court decided in favor of the hospitals, and they were able to get refunds or repayments for those big cuts. Unfortunately, the new Trump administration is taking another whack at it, and they're trying to do it in a way that they think will be more sound, at least legally, by basically conducting what they describe as a more robust survey of Medicare acquisition costs. And then the hospital community is quite worried, at least the providers in 340B, that there will be another effort to significantly cut back the reimbursement for 340B hospitals. The hospitals argue that they shouldn't be basically subsidizing the Medicare program, and that they need the revenue for themselves in order to provide services to their vulnerable patient populations, and that this undermines the very purpose of the 340B program. So I wouldn't be shocked, Shannon and Will, if we see another court case down the road. I don't know. I'm not a lawyer, but I play one on TV on occasion. But I do think that it will be interesting to see if the hospitals have as much success as they did in the last court case.
And then, Will, you wrote about another CMS proposed rule. What can you tell us about that?
Yeah, so the same week that CMS released that other proposed rule, they released another one that maybe flew under the radar a little bit, but has also very significant implications for the 340B program. So is a bit of background sort of separate from this proposed rule. As many of our listeners know, manufacturers have long been required to pay Medicaid rebates when they raise their drug prices more quickly than the rate of inflation. The Medicaid inflationary rebates go into calculating the 340B price. So separate from that, in 2022, under the Inflation Reduction Act, or IRA, a new provision was established that required manufacturers to pay Medicare rebates when they raise their prices there more quickly than the rate of inflation. So Medicare inflationary rebates don't go into the 340B price, and the IRA specifically instructed CMS to exclude 340B claims when calculating the Medicare inflationary rebates. So for our listeners closely involved in the 340B space, as you probably know, identifying 340B claims upfront that are billed to Medicare is much easier said than done, particularly as it relates to Medicare Part D, because in that situation, often, the prescriber doesn't know at the point of dispense whether or not a claim is 340B eligible. It's typically done in the future retrospectively. So in order to sort of address this problem of figuring out how many 340B claims there are in Medicare to exclude from this inflationary rebate, as part of this humongous 2026 physician fee schedule proposed rule that CMS released earlier this week, they have in it two proposals that would, for the first time, use claims-based approaches for determining which claims billed to Medicare Part D are 340B eligible. So at a pretty high level, like the first potential methodology involves basically looking at prescriber and pharmacy identifiers and matching that with existing 340B data to determine whether or not a claim is presumed to be 340B eligible. The other proposal involves a claims data repository where covered entities would submit claims data on Medicare Part D claims to CMS. So the proposed rule says that in 2026, there would be a testing period, but it also pretty strongly encourages covered entities to voluntarily submit claims data to CMS and hints at the fact that this could eventually become mandatory. So I might have gotten a little too in the weeds for a podcast, but basically the main idea here is that, CMS for the very first time has concretely indicated that it's going to move toward having a claims-based approach to identifying 340B claims within the Medicare Part D space. So how CMS goes about doing this, particularly as it relates to a data repository, will have really big implications for the 340B community, not just in this specific program, but it also could potentially affect, how CMS approaches intersections with the 340B program in other areas. As our listeners know, a separate IRA program, which is the Medicare Drug Price Negotiation Program, also a lot of stakeholders have been saying that there needs to be some kind of way for manufacturers and providers to determine whether or not a claim under Medicare is 340B eligible, because there's the prohibition on duplicating the 340B price and the negotiated maximum fair price. So this proposed rule that I'm talking about now doesn't have to do with that part of the IRA. But, if CMS is developing this data repository, it could potentially apply to other areas down the road. So it's certainly something that providers are really going to want to be, and stakeholders in general are really going to want to be paying close attention to and potentially commenting on before the rule gets finalized.
Well, that's quite a busy week in the world of CMS. I mean, two important proposed regulations coming out within, about 24 hours of each other. I know that kept both of you busy this week. Switching gears, Will, can you give us an update on what's happening when it comes to the battle over whether 340B rebates will be permitted?
Yeah, I feel like our episode would not be complete without at least mentioning 340B rebates, which have been really dominating the news cycle for a while now. But yeah, so the two main things happening are, first of all, within the past 2 months, two different federal district judges have ruled that drug makers cannot implement 340B rebates without prior approval from HHS. A lot of those drug makers have appealed that. So that would be J&J, BMS, Novartis, and Eli Lilly all have ongoing appeals. It's looking like at this point, those appeals are going to operate on an expedited schedule, and there could be oral arguments as soon as September. At the same time, 340B Health, the hospital trade group, has intervened in all of those cases, and they filed their own cross appeal that's basically seeking an even broader ruling than what the district court ruled. 340B Health believes that the 340B statute categorically prohibits all rebates. So essentially, it doesn't matter what HHS says. They're saying the statute says drug makers can't implement rebates under any circumstance. So drug makers are opposed to that. Providers are very opposed to the drug makers. So it'll certainly be interesting to see how those appeals pan out, and in particular, if they confirm or overturn the district court rulings. Separate from all of that, HHS submitted to the Office of Management and Budget proposed 340B rebate guidance at the very beginning of June. So this is sort of the last formal regulatory step that takes place before an agency officially releases guidance, and that guidance becomes public. So during this review period, a ton of stakeholders have been meeting with officials at that regulatory office and HHS, HRSA, OMB to try and influence the outcome. And an attorney I spoke to who previously worked at HHS and HRSA said that it's actually pretty common for guidance documents to change based on these stakeholder meetings. So certainly very high stakes, and these meetings really could impact the final result. So we've seen all kinds of stakeholders meet with OMB recently. There's the drug industry. We've seen, pharma. We've seen J&J. We also saw AbbVie, who is not currently suing to implement a rebate, but presumably, like many other drug makers, wants rebates to be allowed, and should a ruling go in their favor, would try and implement their own. On the provider side, we've seen a ton of the advocacy groups, American Hospital Association, America's Essential Hospitals, National Association of Community Health Centers, 340B Health, and others. They've had their own meetings. And then we've also seen 3 different technology vendors. So Calderos and Beacon Channel Management, which are both software platforms that drug makers could use to effectuate 340B rebates. Drug makers contracted with them as part of their proposed rebate models they were trying to implement earlier. They've met with HHS. Also, RX Paradigm, which bills itself as having a neutral claims clearinghouse. They've met with OMB as pitching themselves potentially as an alternative. They have the backing and support of some providers who joined them in that meeting. So, it's certainly interesting that not only are drug makers and providers meeting there, but these vendors that potentially want to be playing a role in any guidance that comes out are also pretty aggressively meeting there. So we will be closely following that and letting our listeners and readers know as soon as there's any major movement there.
Yeah, I know we're all anxiously awaiting to see what exactly is in the guidance there. So thanks for Will for that. Before we wrap up today's podcast, Ted, I know you're mourning a big loss that you wrote about in a column that was published in our most recent issue. Can you tell us more about David Gergen? Who was he, and what role did he play in your development?
Sure. Yes. So David was my first boss in Washington. David had been an advisor at that time to 3 U.S. presidents working at the White House, and he's a really impressive orator and writer, and was a communications director for a few different presidents, and seemed to know everyone in Washington on both sides of the aisle. I was very lucky to get hired by David in 1990 when I first left college and moved to D.C. And I helped him on everything from drafting his editorials for U.S. News, the back page of U.S. News, to getting him prepared for his many television appearances, including his weekly appearance on PBS, the NewsHour, which was a lot of fun to get him ready for those. I also was helpful to him on speeches and all of that, but the truth is he really didn't need much help at all. Maybe a little bit of research, but he was such a good writer and wrote more speeches than I will ever possibly be able to write, and was also ended up writing two best-selling books, became a professor at Harvard University. He was also very involved with my alma mater, Duke University. David encouraged me to go to graduate school at the Sanford Public Policy School at Duke. David grew up in Durham, where Duke is located. And David was just a tremendous mentor to me. I send my condolences to his wife, Anne, their family. They were just a great family, and I really, really miss David and appreciate all he did for me over the years. And it just sort of underscores the importance of being a good mentor. And I hope I'm being a good mentor to both of you guys as we learn more about this very complicated drug discount program.
Yeah, definitely, Ted. I think we've both benefited from your vast knowledge of this program.
Well, Will, you seem to be silent. Have you not benefited from my vast knowledge of this program?
Oh, I for sure have benefited, Ted.
Okay, well, that's good. That's important. Finally, for those of you who are attending the 340B Coalition Summer Conference in Washington, D.C., please take a look for Shannon and me. We're both going to be at the conference. Shannon will be covering the keynote speeches for 340B report, and I hope to be able to network with a number of familiar faces as well as new faces. Don't hesitate to reach out to Shannon and me, and perhaps you might even run into Will, who is not going to the conference but will be around a bit, and hopefully you'll get to say hello to all three of us. That brings us to the end of today's episode. We'll continue to keep an eye on all things 340B related and be back in 2 weeks with a new episode. Of course, we will report on anything that happens in the meantime on our website. Please follow along with our twice-weekly newsletters, which come out each Tuesday and Thursday. And just a reminder, if you're not a current subscriber, you can take advantage of our 25% discount by going to 340breport.com and clicking the subscribe button and using the discount code podcast25. Thank you for joining us, and we look forward to seeing you in 2 weeks.